everyone. My topic was a comparative study of adductor, magnus and parasacral ischial vein approaches for sciatic nerve block in lower leg surgeries, a prospective randomized clinical study. The literature outlines the use of ultrasound-guided sciatic and femoral nerve block for lower leg surgeries in high-risk patients with cardiorespiratory or head injuries. The anterior sciatic nerve block is noted as a more advanced block, while the posterior approach is easier but less comfortable for the patients, and simultaneous use of peripheral nerve stimulator helps reduce the complications. Lack of comparative literature on the anterior adductor magnus and posterior parasacral blade approaches, leading to the current study's aim of comparing sensory and the motor blockade characteristics, analgesia of the anesthesia requirements, and the patient satisfaction. The sciatic nerve block anesthetizes the posterior knee, hamstrings, and the lower leg except the saphenous nerve area. The posterior femoral cutaneous nerve supplying the posterior thigh is not blocked in the anterior approach as it branches of the proximal knee. The given image shows the distribution of the femoral nerve block and the femoral nerve anatomy. My primary aim was mean time to achieve onset of the sensory block following the sciatic nerve block. My secondary aim was assessment of the sensory block, assessment of the motor block, requirement of the additional analgesia and the anesthesia, block performance time, hemodynamic parameters, patient satisfaction, and perioperative complications. Patients admitted in the SCIATIC who are undergoing lower leg surgeries were under my study. After taking clearance from the institutional ethical committee, and it is a type of prospective randomized single-blinded study, sample size was calculated from a pilot study of 10 patients comparing sensory onset between the two groups using 95% confidence interval and 90% power. 19 patients were needed for the group. For validation, 30% were included in the each group. 45 to 70 kg weight and 18 to 65 years of sex, patient posted for the lower leg surgeries, foot, ankle, tibia and tarsometatarsal surgeries were under my inclusion criteria, and patient not willing for the procedures, patient with coagulopathy, local infection, pre-existing neuropathy, hypersensitive to the local anesthetic drugs, and with significant history of drug or alcoholic abuse were under my exclusion criteria. Group A1 were given the sciatic nerve block by the adductor magnus approach along with the femoral nerve block. Group BAB were given sciatic nerve block by the parasacral ischial vein approach along with the femoral nerve block. All the blocks were given by me under the guidance of my PG guide, and study parameters were assessed by my colleague. Pre-anesthetic checkup, written and informed consent was taken, patient prepared and pre-medication was given. Total of 32 ml of drug solution was prepared, 16 ml of 0.5% bupivacaine, 16 ml of 2% lignocaine, 5 microgram ml of 1:2 lakh dilution adrenaline. For the sciatic nerve block, 25 ml of the drug was used, and remaining 7 ml was diluted with the 7 ml of sterile water, and total 14 ml was given in the femoral nerve block. All these materials were used in study. Aseptic precautions was taken for the each nerve block. In group AMM, patients were given the supine position. Curved area ultrasound transducer was positioned 8 cm distal to the inguinal crease to locate the sciatic nerve posterior medial to the lesser trochanter of the femur. Probe was moved 1.5 to 2 cm distally for a clear view of adductor magnus. Needle was inserted and advanced until the needle tip was close to the posterior surface AMM. Confound with the PNS, and 25 ml of the prepared drug was administered. In group PAP, patients were given the Sims position. Probe was placed along the line joining the greater trochanter and posterior superior iliac spine. Probe moved inferior-medially from the PSIS to identify the posterior medial ischium and overlying piriformis at the greater sciatic notch. Needle was inserted targeting the posterior medial ischium, confounded by the PNS, and 25 ml of drug was given. After the sciatic nerve block, femoral nerve block was given, 14 ml of prepared drug was given as shown in the image. All patients were observed for the sensory blockade onset time taken from the injection of the drug till the initiation of the sensory block, and also observed for the motor effect for the sciatic nerve block checked by the movement at the ankle joint. All patients were observed for the total IV injection fentanyl dose requirement before the surgical incision and after the surgical incision. Intraoperatively, if IV fentanyl dose is inadequate, then local infiltration was administered. If IV fentanyl and local administration both were inadequate, then IV ketofol was given. Patient was allowed for the surgery after achieving grade 2 for the sensory and grade 1 and 2 for the motor block. Patient satisfaction score, perioperative monitoring and perioperative complications were also observed. Statistical data was analyzed by the student t-test, chi-square test and man-with test. Significance was considered as follows. Demographic data were comparable for both approaches. As shown in the graph, mean sensory onset and complete sensory onset of sciatic nerve was significantly lower in the PAP approach, whereas motor onset and complete motor block of sciatic nerve were comparable for both graph, requirement of the injection fentanyl was significantly lower in the AMM group before the surgical incision, whereas it is significantly higher in the AMM group after the surgical incision. Median for the incidence of perioperative IV fentanyl requirement in PIP approach was higher than the AMM approach. Local anesthesia and IV ketoform requirement had no statistically significant difference. Hence, success rate had no statistically significant difference between the two approaches. Patient satisfaction was highly significant in the group AM than in the group PIP. In the present study, USC guided sciatic nerve blocks performed using the AMM and the PIP approaches compared for the block characteristics. The results showed a statistically significant difference between the AMM and the PIP approach with respect to the sensory onset and time to achieve the complete sensory effect after the completion of sciatic nerve block, which was earlier in the patients treated with the PIP approach. The possible reason could be the proximal block is given deep to the piriform is given and drug deposited close to the neural structures. Similarly, A. Kadir also found the same results, whereas Junichi-Ota et al. Didn't find any difference between the two approaches. No significant difference in the motor block was found. Injection fentanyl use before incision was significantly higher in the PIP group, likely due to the pain from repositioning. Intraoperative fentanyl use was higher in the AMM group, attributed to the sparing of posterior femoral cutaneous nerve and tourniquet-related pain. So we found that in surgeries without a tourniquet, the AMM approach did not require any additional anesthesia. Median for overall fentanyl use was higher in the PIP, though differences were statistically insignificant, as PIP patients experiencing more positional pain and AMM patients experiencing more tourniquet pain. Similarly, A. Kadir also found the same results. Patient satisfaction was significantly higher with the AMM approach because it minimized the positional discomfort, whereas A. Kadir reported greater satisfaction with the posterior approach due to the less tourniquet pain, while Alcetti et al. Found no significant difference. Intraoperative anesthesia success rate, sensory and the motor block durations were similar in the both groups. Junichi-Ota et al. And Alcetti found comparable block quality between the two approaches, though A. Kadir found better anesthesia quality in the posterior approach. The PIP approach had a faster sensory onset, while the AMM approach was equally effective and better suited for the patients unable to assume the lateral position. Optimum pain control was achieved with preoperative analgesia in the PIP approach and intraoperative analgesia in the AMM approach, with whom tourniquet is required. These are my references. Thank you.
Hello. You have, apart from your comparison, you have mixed two local anesthetic drugs, right? What is the advantage and what is the disadvantage?
Can you repeat again, sir?
What is the advantage of mixing two drugs, local anesthetic?
Yes, sir. Lidocaine has a faster onset, whereas the buprenorphine has the prolonged action, sir. So,
if you go for pharmacokinetic, lidocaine has pH of 6 and bupivacaine has pH of 5.3. So when you mix, what happens? It reduces the concentration. 0.25% will be bupivacaine and 0.1 only 1% will be lidocaine. And because of pH, that will lidocaine become more acidic and bupivacaine become basic. When lidocaine becomes acidic, so it will delay the effect. Onset of the lidocaine will be delayed. And bupivacaine, what happens with bupivacaine? It may precipitate. So its effect will last lesser. So these are the problems. And bioavailability with what I say, protein binding will be also less because of your up concentration. So this funda of combining two drugs is not that much advantageous in my view.
Okay, so just two quick points. In your sample size calculation, you mentioned that you had to do 19 patients next week.
yes, sir.
But you did 30.
Yes, sir.
Why did you do that?
So in the sample size calculation I have got 19. For the authentication process we have taken 30, sir. So because some may be dropouts and some are not included in the inclusion criteria. So we have taken 30 overall, sir.
Oh, but you are. So, in general, let's say one of your blocks is a very difficult block with a high complication. Suppose, is it justifiable to do more patients than required and expose them to the risk of a more difficult or a complex block? Just ethically speaking. So, just keep that in mind. I mean, 19 if you do 22 or 23 or something, it's okay. From 19 if you jump to 30, then you have to justify that.
Okay, sir.
Secondly, please don't use words like ketofol.
Yes, sir.
You give a mixture of ketamine and propofol or whatever it is. Ketofol is okay when you're talking to your friends in the OT, but not when you're presenting a paper.
Okay.
The last thing is, how did you assess sensory block? Did you assess to pain? Did you assess to pinprick? Did you assess to knife? And what was the
Sir, spirit soaked
stimulus that was
gauze
given?
piece, sir. Spirit soaked gauze piece, sir.
Spirits of hospice when you're looking at pain. Cold.
It is cold, sir.
Cold, right? So you make that, also specify that in your method. In the ideal way, you would get something liquid at a fixed temperature in a tube or in a metal tube and then apply that stimulus. Again, as far as scientific methodology is concerned.
Regarding this study, first of all, you are designed for two approaches.
Yes, sir.
How an approach really affects the onset, motor blockade, we are going to analyze the same nerve from different approaches. So what prompted you to have two approaches? Is it a patient comfort? Is it anesthesiologist comfort? Is it some guide's comfort that this approach is maybe something in mind before you develop the background that you showed maybe not suitable to design the study on the basis of approaches. Yeah, we have different criteria. Suppose go for the supraclavicular, intrascranial or some infraclavicular block for the brachial plexus. The approach may be ease of doing the things. But now in this study, you have set the positional discomfort or a tourniquet pain
Yes,
in
sir.
the two groups. Tourniquet pains occurs only when the patient is under the surgical procedure. So that means your block was not affected when the patient was experiencing a tourniquet pain during the surgery.
Sir, in adductor magnus approach, there is a spreading of posterior femoral cutaneous nerve that doesn't supply the posterior aspect of the thigh, sir.
So that means you have developed your study already in a biased manner. You don't want to block all the nerve, recess nerve, the posterior cranial of thigh. So you have already developed a bias in doing the blocks. So definitely that is going because of the pain. The positional discomfort also depends upon the patient to patient.
Yes, sir.
Patient may not be, liking the supine or the prone position or whatever the position, not for the block. It's the positional discomfort is during the surgical procedure that is more appropriate. For a block, it is hardly for your 5 minutes and you are doing ultrasound. And have you compared the BMIs of this patient?
Yes, sir. BMS are comparable in both the approaches.
How many of these patients were there?
So we have taken only up to 70 kg weight, sir.
Can you show me the method of this slide once again?
Yes, sir.
Thank you.
Five to 70
70
kg.
kg.
Height, BMI is not there. See, that is important part when you are using the approach, the obesity, the landmarks, the approach, the depth. So many things have to be compared in this patient, and definitely in a obese patient, you are definitely going to get some different results than in normal lean and thin patients. That's an important part of this.
Okay, sir.
Thank you.
Thank
Thanks. Our next presenter is Dr. Kinjal Parmar. Comparison of dexmedetomidine infusion versus clonidine infusion for induced hypotension and polygamic guilt for middle ear surgery under general anesthesia.